So I'm a medical oncologist, hematologist, and I am the managing partner of New Mexico Oncology Hematology Consultants practicing at New Mexico Cancer Center. And in 2012, I applied for the first grant I ever applied for in my life, and I got it. And it was $19.8 million to take the processes that we had created at New Mexico Cancer Center and see if we could expand that across the country to meet the triple aim of better health care at a lower cost. And what we call what we did being an oncology medical home. So I'm going to try to explain to you what an oncology medical home is, and I'm going to do it by telling you a story. It's actually a true story. It's about a patient named Larry, who is an 84-year-old retired physics professor who had metastatic pancreatic cancer. He knew his prognosis, but he wanted a year. He didn't want to die in a hospital. And he told his buddies from the physics department that he wasn't moving to New Mexico to live with his family while he died of his cancer. He told them actually that he was really running off with a Las Vegas showgirl. So one morning, Larry woke up and he was sick and confused. So his family called my office, where the phone was answered on the second ring by a human being who found out very quickly that it was a call because he was sick, transferred him immediately to the triage oncology nurse, who activated the pathway for confusion, got him an immediate appointment. He came in within about half an hour, 45 minutes. By the time he got there, he was really sick. Low blood pressure, low oxygen, very, very sick. Within the next hour and a half, he'd gotten fluids and antibiotics because the nurse had been able to activate all of the orders for sudden onset confusion. We had checked his lab work to see what the problem was. He'd had a high-resolution CT scan to rule out a blood clot in his lung. And 5 hours later, when the hospital finally had a bed available for him, he was awake and alert and not confused and was pleading with me not to admit him to the hospital because his family was going to take him to Las Vegas that next weekend and he didn't want to miss that trip. A week later, he came in. We did put him actually in the hospital, and the next morning he was much better. His major complaint that morning was that the hospital coffee was terrible, which it is. So I knew that his mental status was back to normal, but we kept him there overnight. We let him go home. He finished his antibiotics in the office. And when he came in for his next chemo appointment, he brought me this picture. He also emailed this picture to all of his buddies in the physics department. There are no quality measures to measure anything of what we did. But let me suppose that Larry had been in a different practice that was not an oncology medical home. When he woke up and was confused that morning, his family would have called the office and they would have gotten, if this is a medical emergency, hang up and dial 911. So they would have dialed 911, where he would have gone to the emergency department, where a guy who is a do not resuscitate order, metastatic cancer, confusion, would have been at the back of the line before people with heart attacks and preterm babies and everything else that goes on in emergency departments. So by the time they found him, he would have gotten really sick by the time he got to see the doctor. In the meantime, of course, the emergency department staff would have confirmed his code status, queried his family about whether or not he smoked, drawn a hemoglobin A1C, and gotten yet another pneumonia vaccine for him, just hitting 4 quality measures right out of the park. But when he went into the hospital after a 5-hour wait, he would have been sick. He might have gone to the ICU. He definitely would have had at least a week or 2 stay in the hospital. He might have died. But all the quality measures would have been perfectly met in the hospital, except, of course, for the oncologist who gave him chemotherapy within the last month of life and didn't have him on hospice. So which of these is actually better care? So as taking care of cancer patients for about 30 years, I figured out that whenever they go into the hospital, even if they don't get the bad bugs, And even if they don't get the blood clots, et cetera, their quality of life is just a little bit worse every time they come out. So I started working on processes in my practice to keep people out of the hospital. So when I got the CMMI grant, I could take a lot of those processes and I could put computer programs behind them so that I could take what we call our triage pathways, which is a series of decision support where I have oncology nurses sitting on the phone talking to patients as they call in. We have first responders instead of that recording. That was the first thing I got rid of. And we have people who can transfer that patient immediately to the triage nurses. We have 32 symptom-based protocols that if you call in with a symptom, the nurse has the decision support to make sure that you are being directed to the right side of service. And that means two things. One is we can care for patients really quickly, and where the people who know them, know their disease, know their drugs, have their charts, know what they're allergic to, and who they are as people. It also means that we can save patients a lot of money. Cancer patients are twice as likely as other patients to go bankrupt. Cancer patients, all patients, have a high risk of declaring bankruptcy, and 2/3 of those have insurance. And the average amount of money that a senior on Medicare, and actually that anybody in the US has for emergencies, is about $500. And that doesn't go too far for those high deductible copays and co-insurance processes. So we created this system to try to affect the price of what we were doing. The other part of it, besides the triage pathways, which is really the heart of it, is the diagnostic and therapeutic pathways, because we knew we would have to be able to prove the quality of care we give, because we didn't want anybody to think we saved a bunch of money by rationing care. So we can prove that we can extract data and show that we gave all of the people who had HER-positive breast cancer, they got their Herceptin. People got the care that they needed, and we could prove it. And the data support system that we created that extracts the data out meant that our doctors were not data entry clerks, but actually got to spend more time with their patients. And so that was key. And the CMMI grant also allowed me to pay the practices that participated in this for the things that are not paid for under a fee-for-service system. I can't pay to have a nurse on the phone. I can't pay for all the patient education that we did in Come Home because there's no fee for that particular service. We had to leave openings in our schedules so that if somebody needed us that day, we could be there for them. But if nobody showed up and didn't need us that day, I still had to pay the light bill. So we still had to have those extra gaps in the schedule. We had to stay open on weekends and later in the evening because we have to be available for patients when they need us, not when it's convenient for us. And the result of all this was that we saved Medicare a fair amount of money. It's $224 per patient per month. And we discovered that we did this by decreasing the amount of inpatient days that we had our patients in the hospital. I was concerned about this because if we're blocking hospitalizations, I didn't want people to stay home and get sicker and then be in longer. But really, the number of hospital days that we created is significantly less. So the blue bars on this graph are all of Albuquerque, and the red bar is my practice. In Maine, they have a great thing that I really want. It's called an all-payer database. So in Maine, we were able to take the main practice, which is New England Cancer Specialists, which is a fabulous practice. And they were able to look at how well they took care of cancer patients compared to the entire rest of the state of Maine. And the different color bars there are the different things, radiation and chemotherapy and emergency department and hospitalization. Hospitalization is actually the biggest spend for cancer patients. You heard a lot about the drugs, but they're 14%. Hospital care is 54% of the cancer dollar for cancer patients, of what we spend on that. And they were actually able to save about $20,000 a patient by aggressively managing the side effects of cancer and its treatments, keeping people out of the hospital, keeping them home with the people they love. And that's the key. And we all created these levels of savings. Our estimate so far is that for the last 2 years of the 3-year grant, that we were able to save Medicare about $1.6 million a month by keeping people out of the hospital and keeping them healthy. So since we're doing all this great stuff, why on earth are we seeing things that look like this? So this is not the map for cellular phone companies, but this is the map of those practices that have either sold to hospitals or have closed their doors in 2010, and there it is now. So part of why we can save money in individual practices is that if we bill under physician fee schedule instead of hospital outpatient, there's no facility fees. Studies have shown that for Medicare, it's about 50% more if you're in a hospital-based system. For commercial payers, it's about 200% more, or sometimes 300% more for hospital-based care. And even hospital-based outpatient care. And so that is a significant problem if we're losing our high-quality, low-cost providers. So why is that happening? Well, it starts back with our friend that we just repealed this last April of 2015, which is the Sustainable Growth Rate Formula. That top line is how Medicare pays hospitals. Every year they get what's called a market basket increase, about 3%, that goes for the cost of care. So they've gotten a raise. That bottom line is what physicians have been getting. And this scissor graph is why a lot of physician practices cannot keep up, because we hire the same oncology nurses, we buy the same equipment, the same drugs, the same computer systems, the same linear accelerators, you name it. It's all the same. Our costs go up as well, but our prices have been held very strongly down. And then you add in the 340B purchase of drugs by a lot of not-for-profit hospitals, and physician practices can't keep up. So healthcare continues to go up and up and up in cost for the exact same service, making us the most expensive nation on the planet, and we don't get the benefit of great healthcare for that process. So with that, I feel a huge sense of urgency, and that's one of the reasons that I came from New Mexico to talk to people like you today, that what I am seeing as we look at that graph where practices are selling to hospitals and the exact same care now costs us more in a society that cannot afford it, is that we have to act very soon. We have to get back to saying, how do we get the low-cost practices that can deliver the quality? How can we give those resources and tools to physicians so that they in their practices can take a practice and meet the needs of their individual community in a very cost-effective way? We've shown, and the basic premise of Come Home, which stands for Community Oncology Medical Home, was that if you give physicians those tools that work, we can actually deliver the triple aim. So I figured that we, as a nation, need to do it for our economy and for healthcare. As a doctor, I do it for Larry. Thank you.